Today's topic is breast cancer, a very personal subject, and whether hormones can contribute to it or whether they might actually reduce its risk. The reason this is important because many women are eligible for hormone therapy at the menopause, and yet they reject it. And there's a variety of reasons for that. The first is that, well, most breast cancer occurs in women, by a long shot. The second is that if you look at the men who get it, and there are very few, they're taking hormone therapy. Nevertheless, even in transgender patients, it's very rare. And thirdly, because we all have heard of DES, diethylstilbestrol, which was a synthetic estrogen way back that caused a lot of cancers, including breast cancer. Question then becomes, does estradiol, the natural estrogen of women, equate with DES? Are they radically different? And if so, what makes them so different? Breast cancer, it's a mixed bag. You can have anything from a tiny little lump in the breast that is barely visible, might be 1 millimeter or 2 millimeters in size, which probably has a very good outcome no matter what you do. And often these are treated with lumpectomy, and the chances of recurrence are relatively small. On the other hand, you can have very aggressive cancers. So let's not toss them all in the same pot. Let's not think of them as if they are all the same. The second thing is that some breast cancers have what's called estrogen receptor positivity or progesterone positivity. And these tumors, people think, oh, they must be all the more reason to avoid hormone therapy in these people because they have cancers that are estrogen receptor positive. Well, that may not be true. Let's look at the context for all this. Many years ago, when I was a medical student, the women who got breast cancer were women who never got pregnant. And those who had the least chance of getting breast cancer were what we called grand multips, or grand multiparous women who had, back in those days, 8, 9, 10 kids. Very great protection against breast cancer risk. And yet these women were barefoot and pregnant, if I'm allowed to say that, from about the age of 18 to the age of 45. That's the way society was back then. Their estrogen levels were in the thousands as opposed to the hundreds. And the same was true of their progesterone levels. And yet, this protected them greatly. But think about it. When those levels are very high, even any flux is minimal compared to the area under the curve of the amount of hormone that's present. It's like a wave on the top of the Pacific Ocean as opposed to a wave in your bathtub. Now, in contrast, those who had many cycles, many menstrual cycles over the years, were at the greatest risk, presumably because of the spike in hormones every year, every month at ovulation. Big spike in estrogen and testosterone. Or maybe because of the ups and downs of progesterone, where progesterone jumps to high levels in the second half of each cycle and then drops to zero, or almost zero. So in terms of progesterone, one has a square wave effect. But the problem then becomes, why does this happen? There must be a mechanism whereby all these fluxes, because that's what we're talking about, flux, causes an increase in breast cancer risk. And this becomes very evident when a woman hits her mid-40s, because then the fluctuations in estrogen especially, become dramatic. There are huge excursions, up and down like a yo-yo, and that's why many women develop hot flashes in their mid-40s. Not because of low estrogen, but because of flux, because it's dipping estrogen levels that cause hot flashes. And I think you're going to agree in a little bit that maybe dipping estrogen levels also may drive the risk for breast cancer. Why? Because of the dipping effects on inflammation and the immune system. "10 years later, early to mid-50s, there's a peak in estrogen receptor positive breast cancers. Is this caused by the flux that occurred 10 years previously? It's quite possible. There are two things that increase the risk of breast cancer at this point in a woman's life. Number one is the profound fluxes as we described them in the woman's late 40s. But the second reason is because of a change in what are known as estrogen receptors. There are three kinds of estrogen receptors from our point of view, and here they are. This up at the top here is a purple cell. I've used it to denote a normal breast cell. It's called as an alveolar cell. And over here we have estrogen receptor alpha. There are two slow-acting kinds of estrogen receptor, the alphas, which promote proliferation. Estrogen receptor alphas are why women develop breasts when they're teenage years. And opposing them are estrogen receptor beta populations, and those do the exact opposite. They are anti-proliferative. And somehow the balance of these in a young woman's life is sufficient for her to develop her breasts. But proliferation and development are different from cancerous proliferation. That's quite different. And the difference relates to a thing called AIB1. You can see it just under the estrogen receptor alpha sign. AIB1s are cofactors that, when present with estrogen receptor alpha, tend to promote breast cancers. Of course, the thing is, we need to develop a dynamic way of looking at breast cancers. Instead of thinking of them as static structures, we need to think of the body constantly developing some breast cancer cells all the time, but then our immune surveillance gets rid of them. And so if we were to do mammograms on people very frequently, we'd find that there might be some little masses in there this month, which might be gone again next month as our immune systems got rid of them. So a dynamic model of breast cancer, a dynamic way of looking at cancer or perceiving it, is important here. And you'll see why in a moment. So here we have the alphas promoting proliferation, if added with AIB1, promoting even potentially cancer, and estrogen beta, receptor beta, acting in the opposite direction. And that explains the difference between DES and the natural estradiol, which is the natural hormone of young women. DES is unique in that it tends to strongly recruit AIB1. Estradiol does not. So let's not demonize all estrogens. DES is a demon. Estradiol is not. In fact, you're going to discover that estradiol per se does not cause breast cancers. Instead, it is the estrogen receptor status of a woman. Now, as a woman gets into her menopausal years, the balance between alpha and beta receptors changes. The alpha receptors are sustained, but there's a big dip in her estrogen receptor beta. So the balance or ratio between alphas and betas dips. And that promotes proliferation, and that promotes breast cancer as well. Now, let's look at the standard way in which people used to treat women for the menopause. They would give them pills of estrogen, particularly Premarin or equivalent conjugated equine estrogens. And these hormones, when taken by mouth, go to the liver, and they make the liver produce a lot of things called sex hormone binding globulins. And as a result, the net effect is there's a dip in testosterone and a dip in free testosterone levels in the body. Excuse me. Why do we care? Because testosterone competes with estrogen receptor alpha. When testosterone enters the body, it switches on testosterone receptors, and they compete with estrogen receptor alpha for the attentions of this bad guy, AIB1. And so that's one of the ways in which testosterone protects people against breast cancer. Problem is, if you take hormones the wrong way, for instance by mouth, you're lowering the available testosterone in the body, and therefore potentially reducing the protective effects of testosterone. The other thing is estradiol and progesterone going to the brain switch off the gas pedals that promote production of testosterone by the ovaries. This is important because even after a woman stops making estrogen, she generally continues to make some androgens both in the ovaries and the adrenals for about 5 years. But now taking the estrogen has inadvertently lowered her testosterone secretion. So estradiol therapy, if done the wrong way, reduces testosterone's production in the body, and it also reduces its bioavailability. It's a bioavailability to the breasts and to the brain. As a result, one loses this benefit of estrogen receptor beta. There are other reasons why testosterone is critically important. Testosterone lowers the population level of estrogen receptor alpha. So yet a second way that testosterone benefits us. Thirdly, when you give testosterone to the body, or when it makes its own, it is converted into a thing called DHT, which in turn converts to a thing called androstenediol, and androstenediol is an 80% selective stimulator of ER beta. In other words, androstenediol is actually an estrogen of sorts, a good estrogen. Why is it good? Because it selectively stimulates beta and not alpha. Finally, they've done studies in New Zealand, was it Australia? In Australia, looking at women who had experienced breast cancer and has survived it. 1 out of 8 women experiences breast cancer at some point during her lifetime. That also means 7 out of 8 women don't have to worry about it at all. But focusing on that selective 1 out of 8 group, excuse me, they looked at women who were in that group because they'd survived invasive breast cancer. And they followed them while treating them with testosterone and estradiol for about 5 years. And they found that testosterone actually reduces the risk of breast cancer recurrence. So testosterone is an important factor, even though many doctors don't give it to women because it doesn't belong in the females. What nonsense. Testosterone has many other benefits, including increased sex drive, great reduction in osteoporosis risk. But let's not get into this today. Let's focus on cancer. This brings us to the ideal way, therefore, to treat the menopause. Should we be afraid to use hormones? I don't think we should, as long as we do it correctly. Remember, we said that flux is important. Why is it important? There's another kind of estrogen receptor called GPERS. These two receptors determine before the fact whether a cell becomes cancerous or not. Then, remember, we said that the immune system surveils everything and kills off cancer cells after they've been produced. And that too is sensitive to estrogen. Using the dynamic model of cancer, GPERS, which are important estrogen receptors, affect not the breasts, but rather the immune system, the brain, and the blood vessels. And those receptors are very fast in their actions, whereas the alphas and betas are very slow and sluggish. Therefore, estrogen flux doesn't matter too much. The GPERS are activated within moments to minutes. And as a result, flux matters. That's the only way that flux could matter, by affecting these particular receptors. Now, the G protein receptors prevent breast cancer by promoting immune surveillance and elimination of the cancer cells. But dips in the GPERS do the exact opposite. Why do I believe this? Well, partially because you've heard of a drug called tamoxifen. Tamoxifen is one of the commonest drugs used to treat breast cancer. And everybody thinks, oh, it's an anti-estrogen. Well, guess what, folks? It's a powerful GPER stimulator. So the ideal treatment of the menopause would be, number 1, use estradiol. Don't give it by mouth. Deliver it in a very steady fashion that minimizes flux. Number 2, progesterone does increase breast cancer to some degree. Therefore, when I give progestins or progesterone, I give them vaginally, either in the form of vaginal progesterone, or I use the Mirena IUD if it's possible to administer it, because it actually protects the uterus from any breakthrough bleeding or any cancer of the uterus, which is all we want of it. The other roles of progesterone affecting the brain, it causes depression, affecting the breast, it might increase breast cancer, are minimized. So finally then, this brings us to testosterone. Testosterone, the only way to give it is in the form of subcutaneous pellets, because they are the only ones who give a steady state delivery system. Let's compare this to what is known as bioidentical hormone therapy. The word bioidentical hormone therapy, or BIHT, is just a buzzword used by marketers to market or sell creams and gels that are compounded and administered to the skin. The problem with these is they're probably, in my opinion, certainly, the most inappropriate hormones to use because they have a very short half-life and they cause tremendous flux. How do I know? I'll give you an example. I have a patient who was started on the bioidentical hormone therapy. Then her gynecologist increased the dose when she said her hot flashes had not gone away. Then she says, my hot flashes got worse. He finally ended up giving her 8 times the standard dose and her hot flashes were worse than ever. Why? Because of flux. Because remember, dipping estrogen levels are what cause hot flashes. And dipping levels of estrogen are what might promote breast cancer. So, to me, the best way to give hormone therapy is as a precise delivery system. I call it precision HRT.